interest that I need to share with you. So that conflict of interest mainly arises from doing a lot of research, clinical trials together with pharma companies. So in the last years, the main interest in conducting trials was into cystic fibrosis as well as bronchiectasis. But as we now have the PCD clinical trial network hosted by Kim Nielsen and Johanna Raidt in Copenhagen and in Münster in Germany, we hope that we have more and more clinical trials that are supported by the pharmaceutical industry in the next years. So today I'm going to talk about some of aspects of the adult treatment, and a lot of overlap is already there with what Jobst just mentioned. So it's not that the people with PCD are very different once they cross the border. So at our institution, we have a transition at 18 years of age, and we take care for adults only. So I'll talk about the treatment basics and the treatment challenges as well. And I think, as Jobst already mentioned, I need to disclaim a few aspects of treating people with PCD. So we have no disease-specific management guidelines at the moment. Hopefully in the next years we will see international guidelines to unify the treatment of people with PCD across centers and across countries and settings. So what I present to you is my personal opinion that relies on the experience made at our center here. And definitely there are more unknowns than things we know about the management of PCD that should be mentioned as well. And as Jobst already mentioned, most of the principles of management rely on the ones established for other airway and lung diseases like asthma, bronchiectasis, COPD, or cystic fibrosis. And why is that the case? As already been mentioned, there are two clinical trials so far that stand the term large randomized control international multi-center trial, and that is the one with azithromycin, specifically conducted in people with PCD, the so-called Bestzilia trial, which aimed at reducing exacerbations in people that used antibiotics for up to 30 days in the past 2 years. And azithromycin actually is already a treatment we use in, or even we used before this study, because it's a generic antibiotic with anti-inflammatory properties. Actually, we don't use azithromycin for its antibiotic properties, actually. And the other one is the clean PCD trial with the so-called ENaC inhibitor idrofluoride, which is delivered in hypertonic saline and which aimed at improving lung function. And this was an early development phase 2 trial. So typically this is nothing we can use in clinical care right now. And the results of this 4-week crossover trial need confirmation in a larger phase 3 trial before we will be able to use this drug in clinical care. So there's only one solution to the paucity of clinical evidence, and that is that you, dear patients and people out there, participate in clinical trials. I'm sorry to say, but there's no way. If you don't do this, nobody will do, and we will continue to have more unknowns than things we know about PCD. And maybe, it's maybe a little bit provocative for some of my colleagues, maybe you will be able to identify a high-quality care center by the question, excuse me, do you offer clinical trials for people with PCD. Just a suggestion from my side. So there are some special aspects of adult care, and as I already mentioned, and this is definitely not the case in all centers, like for example, in Jobst's settings, it is surely very different in different centers, countries and settings. We take over care at age 18. That is called transition. Transition does not start with age 18. Typically, adolescents are getting prepared for taking responsibility for their health between the age of 12 and 14. And this is a more or less year-long process. And I have still lots of things to explain, and surely we will do with patients, two patients at the age of 18, because it's not that easy to find yourself in adult care, definitely. And as Jobst already mentioned, the disease manifestation will change with age. So in adulthood, typically the lower airway disease dominates the upper airway disease, with the vast majority of adults with PCD having bronchiectasis and accordingly symptoms of chronic cough and sputum production and inflammation and airway infection. Of course, this is a lifelong process where I always tell my patients PCD never sleeps, and this is what makes them very different from other adults with bronchiectasis, who may have a day or a few days rest from their symptoms, actually. However, upper airway disease still is an issue and has a tremendous impact on the quality of life, although the development of speech and from relying on the proper hearing is not that important at an adult patient who already is beyond that. So my personal tip for you as patients is to, together with your treatment team, with your care team, define your individual treatment goals. And definitely these goals may vary over time or may change over time, but it's always important to stress that this is your treatment, not my treatment. So in adult care, it's up to the patients, and they need to do the treatment, and we need to talk about these challenges that hinder patients from doing daily treatment in a very open and transparent fashion. Otherwise, I cannot deliver the best possible care. And this is just a brief repetition of what Jobst already mentioned. I'm not going to talk too much about the monitoring of disease, which needs microbiological sampling, nasal lavations, or throat swabs or sputum cultures to be performed, and of course radiological follow-up of patients, be it with computed tomography scans, conventional plain chest X-ray, or MRI imaging. So this may vary over time, but monitoring of disease is a very important aspect, which I'm not going to talk about too much. And I think we already came across this basic treatment principles, which I will not go into detail then. So sports, in my opinion, is the treatment number one for patients with PCD, for people with PCD. It's recommended by WHO to every woman and man alive, actually, no matter if you're having a chronic condition or not. But we all know that it's maybe demanding in a very busy day to perform sports 3 to 4 times weekly, actually. And typically a combination of endurance and strength training is recommended. So physiotherapy is something that is definitely also a basic principle of treatment, but in my setting, it's not very easy to find specialized physios for patients. I know from working internationally with colleagues in different settings that, yeah, the optimal clearance techniques still need to be determined, and they may vary between settings and countries. And for example, in Germany, we have only quite limited terminology in how to call different techniques. So we tend to summarize them all under one big umbrella. So it is very much more differentiated field of even research in other countries. And also pulmonary rehabilitation, we already talked about a little, as we did for vaccinations. So I'm not going through all these different vaccinations, just recommend to refer to your national vaccination schedules. A very interesting thing that we will probably have a little bit more data about in the future is RSV. RSV is another respiratory virus, and we just had this year a vaccination license for people 60 years and older. And it's recommended by internal medicine, infectious diseases, and pulmonary physician societies actually to also vaccinate people with chronic lung conditions against RSV, but still statutory health insurances are quite reluctant to cover the expenses for this new and therefore quite expensive vaccination. So let's talk a little bit about mucolytics, and same with mucolytics, though the approach of mucolytics used vary tremendously between settings and countries, maybe very different from what we do in Hanover or in Germany. I think Jobst and I, both working in a large cystic fibrosis center, will use what we typically use in patients with cystic fibrosis, knowing very well that this is not covered by, not backed up by any well-performed studies, whereas colleagues in other settings may not at all use these techniques. And that's not because they are bad boys or girls. That's because they adhere to what is actually in the medical literature and evidence-based. So there may be oral mucolytics used in few settings, for example, in the UK, in adult care, whereas inhaled mucolytics like saline solutions, which may be applied after applying a short-acting bronchodilator before nebulization, is something that we in our center use. Dry powder mannitol is something we don't use at all, although this may be supported by some limited data in bronchiectasis, and there is a guideline for the management of adults with bronchiectasis that strongly advocates against the use of a drug used in cystic fibrosis that liquefies sputum. It's an enzyme called DNase. The drug's called pulmozyme, and that should not be used in people who do not have cystic fibrosis accordingly. And why is it so different across settings? It's because the devil is really in the details with inhaled mucolytics. So nebulization is time consuming, and adherence to nebulization may be variable or low to moderate, maybe. Patient education, which actually is also consuming resources, is key. So handling should be reviewed by the physios every now and then, and a reasonable sequence of inhalation or nebulization needs to be determined. In particular, this may be demanding if the patients apply multiple inhalations on a day. Special attention needs to be paid to hygiene, actually. So usually we recommend daily disinfection of your equipment by boiling or vaporization, or this again takes a lot of your daily time. And I just want to point out, and this may be very variable across settings, that there are actually nebulizers that support your needs and that you as a patient may prefer. So it's always a discussion we have not only with patients and colleagues outside our center, whether to use jet nebulizers versus vibrating mesh nebulizers that may be rapid and portable, or versus the ones that are residential nebulizers. So here I show you a picture of a so-called eFlow rapid nebulizer that may be used on a mobile base that allows a very fast nebulization, but which is very actually hard to get paid by your statutory health insurance in our setting if you do not have cystic fibrosis. So coming to bronchodilators, I think this is the drugs, or these are the drugs most commonly used in people with PCD, together with inhaled corticosteroids, and I spend a few moments with that. So these are medications licensed for smoking-related COPD. And they may be considered in people with reduced exercise capacity and shortness of breath. So there are multiple compounds and even combinations, and they may be rather easy to apply because they may be powder or they may be in metered dose application, and they are prescribed rather permissively on an individual base, but honestly, it's very hard to figure out the individual benefit the patient has, and probably we all should be a little bit more reluctant to prescribe these drugs, and we should figure out, we should determine the individual benefit more consequently. And on the other hand, the same applies to inhaled steroids. These are medications, ICS we call them, used for asthma and also COPD, and they are used very commonly, but they definitely should be handled quite strictly. And they are only indicated in people that have the evidence of so-called type 2 or Th2 inflammation that can be figured out by different tests like breath analysis or like differential blood counts, and they should otherwise be avoided. So they are used in individuals, and that's quite a remarkable proportion of 20 to 25% in my practice that have concomitant asthma or a fungal allergy that's quite severe, that is called allergic bronchopulmonary aspergillosis, ABPA. Why should they be avoided otherwise? Because they may increase the risk of pneumonia and other opportunistic infections with rare pathogens like non-typical mycobacteria, and there's quite convincing evidence that we should use them in a personalized approach, but only if there's evidence for their use actually. And a little bit we already talked about the azithromycin story. So this is a very important treatment we use, and there's extensive evidence among people with bronchiectasis. So far, it is the only evidenced medicine that reduces the risk of future exacerbations up to half in the future year. But people in the studies had exacerbations treated with antibiotics. So typically we dose this drug 3 times a week, Monday, Wednesday, Friday, 250 to 500 milligrams according to body weight, 40 kilograms or less or above. And these drugs should be used for at least 6 to up to 12 months according to the literature in bronchiectasis. Definitely there should be some monitoring, and in particular sputum cultures before commencing this treatment is definitely important. As you can imagine, as it is an antibiotic that's used for anti-inflammatory treatment, there are some side effects associated with azithromycin treatment that are namely loose stools and diarrhea that are more common, and there may be a small risk of macrolide resistance, but otherwise these drugs would not be used for the treatment of exacerbations. So these are drugs that may be considered in individuals with frequent exacerbations and high symptom burden. So as Jobst already mentioned, there are new drugs from bronchiectasis for people with bronchiectasis in development, and we are really excited to see the results of the ongoing trials, probably next year. Let me talk a little bit about antibiotic treatment. So there are basically 3 indications for antibiotic treatment. That is the eradication of new pathogen detection, the suppression of chronic infection, and the treatment of pulmonary exacerbation. And it's quite important to sort these 3 differential indications for antibiotic use out. Talking about antibiotics, I need to drop a line about a bug called Pseudomonas aeruginosa. So it's by far the most relevant pathogen, actually, and its detection is associated with frequent exacerbation and increased risk of hospitalization, worse lung function, etc. And as people, compared to other people with bronchiectasis, people with PCD may have an increased lifetime risk of acquiring these drugs due to their inherited clearing disorder. And it's commonly perceived that a sustained culture negativity becomes more difficult once the infection has got chronic, although as so often in PCD, a common consensus what is meant with chronic infection is lacking. So there are different approaches, and in the matter of time, I will not go through them all in detail. So far, it is really up to your local protocol at your treatment center, which way to use, be it oral, intravenous, or inhaled, or a combination of all these antibiotic treatments. So it is important to mention that bronchiectasis guidelines advocate not to eradicate other pathogens than Pseudomonas aeruginosa in adults otherwise. So a word about suppression treatment. This treatment is a principle that aims at reducing the bacterial load and subsequent airflow inflammation, and therefore decrease the future risk of pulmonary exacerbations. Sure, if you inhale an antibiotic, it achieves very high drug concentrations in airways and lungs, but it's expensive. As mentioned, it requires a special infrastructure for nebulization. We know that we put on burden for patients there. Tolerance is variable, to be honest. And if you stop it, your chronic infection, if it's really chronic, may recur over weeks once the treatment is stopped. So at the moment, and it's a publication in press, so we need to be patient until it's out and published. There's maybe some advantages for continuous nebulization of colistin twice daily for a duration of 1 year. Nebulized with a special INAP nebulizer over other inhaled antibiotics in people with bronchiectasis. But yeah, the last word in this field has not been spoken yet, to be honest. Cyclic intravenous antibiotics we only use rarely in adult patients. It may be an option for difficult to manage patients, and it may be an option we may be able to use in outpatient settings as well, as we do all this, what I mentioned, in outpatient settings as well, in any way in adult care. So we cannot do anything of that I mentioned so far in the hospital. Okay, in the matter of time, it's important to treat and manage exacerbations with antibiotics. So I ask you to take a deeper look on that later. There's a consensus definition. This is one of the fields that has been progress over the years, where we have a consensus how an exacerbation should be defined, with increasing cough, change in sputum volume and color, shortness of breath, and so on. So typically, it should be early recognized and treated after a short period of 2 days presence of symptoms, and in particular, if there are multiple symptoms according to this definition, 3 or more of the following should be present. I advise patients to get self-management plans. So we provide patients with self-management plans, making suggestions for future antibiotic treatments if necessary, according to sputum surveillance, which we recommend to do twice a year, not every 3 years. So typically the consultation schedule at our center is twice a year, not every 3 months, as it is in CF, because we do not have the resources. So I think extrapulmonary manifestations have already been covered by Jobst. It's basically the same principles. Maybe a word on the cardiac defects that may be present in people. They should be sought, they should be recognized actually, but the same with ENT specialists. Individual management may be difficult to a lack of professional communication with other specialists who rarely know and care about the existence of PCD. And this brings me to my take-home messages. So management needs to be individualized, in particular, as we have only very few evidence for the management, according to preferences and the experience of your treatment team, which should be definitely multidisciplinary, multi-professional. But in adult care, members of this team are often outsourced, and communication with members of the team may be demanding. So it may require you as a patient to be proactive in collaborating with your teams. Thank you for your attention, and I'm open for questions.